In today's session, we highlight the best practices and potentials of using non-lab workers to support diagnostic services delivery. We know that when people come to seek health care and diagnostic services in particular, they start from lower facilities. But studies and reports have demonstrated that there is limited access to lab diagnostic services. Only about 47% do not get the services that they require at the time when they require it. And some of these reports have also indicated what should be done. And one of it speaks to the fact that because we get people accessing services from lower facilities, then we should move diagnostic services closer to the people at the primary healthcare centers. The WHO 2021 Service Delivery Guidelines strongly recommends again that task sharing should be taken up by programs and countries, so that then the testing services and general diagnostic services can be made available to the people who need them. Unfortunately, when we do task sharing with lay providers and other healthcare workers that are not lab workers, the contribution they make is not ultimately recognized. And today, therefore, we have two presenters who will be sharing with us how this can be done and made better. Our first presenter will be Z Ndlovu. Z is an epidemiologist and a lab advisor with Medicine Sans Frontiers, based in Cape Town, South Africa. He will share with us how testing initiatives that center on lay cadres and non-lab personnel can scale up access to essential point of care tests using the case study of the early infant diagnosis. Z will be followed by Patrice Chenju. Patrice is the country director for Elizabeth Glaser Pediatric AIDS Foundation and is based in Cameroon. He will present the experience of task shifting and the lessons learned by non-lab medical staff taking on the diagnostic services delivery without necessarily compromising on the quality of services. Colleagues, join me in welcoming our presenters for today, and we'll start with Z. Z, over to you.
Thank you for inviting me to this very important talk. So I was invited to conduct this session based on this recent publication that I made in PLOS Medicine Journal, where we tried to provide justification for the need to strengthen and formalize lay testing cadres to support point-of-care testing in primary health facilities for HIV service delivery, but also for other priority diseases with significant unmet needs. So I'll encourage each and every one of the participants here to have access to this article, because here we have very limited time to go through what was published in this article. And this is the outline of my talk. I'll talk about general availability of point-of-care tests at primary healthcare level, and I'll also talk about the current status quo of the task shifting. And lastly, I'll talk about the need to scale up task shifting for point-of-care diagnostic tests. And my key words, they have underlined them. It's primary healthcare facilities, abbreviated PHC, and lay testing cadres or lay health workers. So pardon me if I just use the abbreviation going forward. So primary healthcare facilities are the first point for seeking healthcare, and they tend to be closer to homes of people. And point-of-care diagnostic tests can provide the first critical step in effective patient management, and they can enable earlier detection of diseases before patients develop severe conditions that necessitate hospital admission. Colleagues from McGill University, Jacob Biggio and et al., they published recently, I mean, it's from a few weeks ago, this publication in May, and it's a systematic review that gives us an understanding of the most common symptoms that patients present with at primary healthcare facilities, and they provide a given diagnosis. As you can see on the right side of the picture, the column on the left and on the right, This study was conducted in 7 countries. This systematic review, it included South Africa, Nigeria, India, Brazil, Bangladesh, Cambodia, and Malaysia. But this study is very important because it gives us an idea of what patients present with at primary healthcare level, especially as we now are planning for strengthening for systems for universal health coverage, for sustainable development goals. But right now we're talking about the need for task shifting. At the end of the day, we need to understand what do patients present to facilities with. So the question basically to ask is, do patients find the diagnostic tools available for these common symptoms during these visits? As you can see from the left, the common symptoms include headache to fever to cough and the like. And on the right, the diagnosis given is hypertension, upper respiratory tract, and they were ranked in score from the most common. So as I've already said, the question is, do patients find the diagnostic tools available? And also, does availability equate to accessibility or utilization of these tools? To answer that question, we have had a series of Lancet reviews that have described the lack of access to diagnostics. And in this systematic review done by Harika, it looked at health services data from the lab and also from the diagnostic imaging. And it was meant to assess the availability of essential diagnostics in 10 low and middle income countries. As you can see, they found a median of availability of diagnostic tests of 19% in primary healthcare facilities. And as you move up the tier from primary healthcare facilities to hospitals, we see that the availability increases to 68%. And I mean, this pattern of availability is not surprising given the enormous funding that we know has been channeled in secondary and tertiary facilities for HIV and other vertical programs. Actually, in fact, this lack of priority in primary healthcare facilities might explain why populations largely avoid primary healthcare facilities and prefer to go to secondary facilities, even for essential care services like your antenatal care, because they know they will find comprehensive package of services at the hospital level. And this other commission from the Lancet, again, is showing poor access to diagnostics globally, with 47% of the population with limited access. So the question to pose after this study is basically seeing these gaps, do we have any supportive framework or guideline that can help us to improve availability of these essential diagnostic tests at primary healthcare level? And yeah, we have partly some of these guidelines. So the WHO has released 3 editions of its essential in vitro diagnostic list. And the latest was from last year, as Francis has already mentioned. And the essential diagnostic list basically is a basket of recommended types of tests to support the diagnosis of diseases at different healthcare levels, from community even to healthcare levels like the primary healthcare levels without laboratories. And as you can see from the slide, we upload Nigeria. Nigeria is the first country in the African continent that has adapted and the WHO EDL to its own national essential diagnostic list. And of course, we recommend other countries to do the same. Now, the question again from this slide is, even with the national essential diagnostic list, will the availability and accessibility of point-of-care tests to the masses be guaranteed? And of course, availability doesn't equate to accessibility for the populations. We've also seen that there's user fees that are prohibitive to the access. And also we know that conducting point-of-care tests has been shown to be a burden on healthcare workers like nurses and clinicians, whom we know they are in short supply. And worse still, we know that most primary healthcare facilities have no laboratory trained staff. So in essence, when new point-of-care tests are released year after year, they are unlikely to realize the maximum impact of disease testing. And after this slide, the question is, how can we improve accessibility to point-of-care tests for patients in decentralized health facilities? Since 2008, if I'm not mistaken, WHO has always recommended task shifting. And task shifting, I mean, is defined as the rational redistribution of tasks from the higher level cadres to healthcare professionals who are less trained within that scope of work. And this recommendation more or less has been mostly within the HIV continuum initially, but the explicit language that comes to diagnostics came in 2016, as you can see from there. And it was more of a practice statement that regarded sample collection by non-lab trained people. However, in 2019, based on the review done by Lara Vojnov, WHO more or less recommended that trained lay cadres can independently conduct safe and effective HIV testing services. And we've also seen that more evidence has also supported WHO to give even more guidance with the latest guideline of last year that strongly recommended that task sharing of specimen collection, even of testing with non-lab trained personnel should be possible. So now the question after this slide again is, we have the WHO Essential Diagnostic List, which is now on the third version, as already mentioned. And we also have these WHO recommendations for task shifting, including the evidence we have from different studies that have shown that task shifting can have maximal impact. So the question is, why haven't programs and countries fully adopted task shifting to improve diagnostic accessibility in primary healthcare facilities? So from this slide, you can see that we're now looking at the challenges why countries have failed, and implementation of task shifting basically has proven very difficult to implement in different settings. And you can see from this slide that shows David Flynn's review of national policies from about 50 countries. And he showed that about 42% of HIV testing policies, 42% allowed lay cadres to perform HIV testing, meaning that majority of the countries limit these roles, HIV testing, to more trained lay cadres, probably based on concerns that they're saying lay testers may have difficulties in doing these tests or provide inaccurate results. Another encountered limitation to task shifting is the lack of integration of lay cadres to the human resource structures in national programs. And the third point there, we've also seen that in many places, non-governmental organizations normally are the ones driving the implementation of lay testers in many programs. Even they are responsible for the remuneration of these lay testers. Of course, this limits sustainability of such a program. Again, legal structures that enforce the strict professional boundaries that allow testing only to be conducted by non-lab, by lab-trained people and hinder non-lab trained people are also the barriers. But lastly, the elephant in the room that we've seen in so many areas is the resistance from medical laboratory councils or associations or laboratory technicians who may not be willing to endorse task shifting for certain point of care tests. And of course, this is either related to protecting professional turf, or it could be financial interests, or it also could be concerns of quality related to allowing lay testers to conduct this test. However, as you can see also from the last point there, it's not necessarily all doom and gloom that all countries have failed to implement task shifting. I'll mention Malawi, for example. They have, but through the support of an NGO, implemented a health diagnostic assistance. It's a lay cadre that has been involved in the scale-up of point-of-care testing. And in Zimbabwe, I've been informed, of course, that there is a bit of registration of lay testers who are trained. And in Kenya also, I've heard that there is the association of lay testers, and also in Uganda, there is some activity happening there. So it's not necessarily doom and gloom, but it's a bit difficult to find exactly the extent of where task shifting is, but nonetheless, there's quite a lot of challenges to the scale up of task shifting. So from our PLUS policy publication that I showed you earlier on, we basically argued that national programs currently have different lay health workers whose scope can be broadened to take up this role of point-of-care testing in decentralized facilities. And this can start with the review of the existing roles and responsibilities, together with an analysis of the existing gaps. It could be looking at gaps in testing. It could be looking at the quality of point-of-care testing. It could be looking at responsibilities of who can do the testing, but also it could also then thereafter follow up planning for a training and supervision for the conducting of these point-of-care tests. We developed this table. It's also available in the publication, but essentially this table highlights the possible cadres who could be considered for point-of-care testing at decentralized facilities. This is your primary healthcare facilities. And as you can see from the extreme left, we're trying to highlight what cadres are available, and their roles may need to be reviewed and assessed if they could be the ones responsible to take up the task of conducting point-of-care tests. For example, I'll talk about the HIV testing and HIV testing services counselors. I think most of us, we know that pre-test counseling, especially that with individualized risk assessment, is no longer recommended by WHO because it can create barriers to service delivery. And also we have a lot of other healthcare workers who can do it, who are equally capable of this. So these lay cadres could primarily be responsible for the scope of other point-of-care tests. But other than that, I mean, there's also a list of different cadres, as you can see there. It depends from country to country what cadres are there, but it comes back to national program managers initiating that review to see who's responsible for what, and initiating that analysis to result in the training for these cadres. Before I move on, of course, in the middle here, I also highlight the kind of point-of-care tests that can be conducted by this cadre, your HIV rapid test, going all the way to nucleic acid tests, which are your near point of care. So in essence, most of these tests hardly are used to their maximal benefits because there's no responsibility for their use in most primary healthcare facilities, or sometimes they are not available. So that's the question that we're saying is, once we have a framework of how to ensure that there's a responsible cadre for this, it can go a long way in helping us to eliminate and control certain diseases of priority. And these cadres can also be responsible for sample collection, as I've mentioned here, but also for other tasks like navigating priority results to clinicians, quality controls for those point-of-care tests, but also referring samples to higher labs and stock, following up stock management, among other things. Now, the question is, of course, what are the key enablers to ensure that this can work? And top priority, of course, are the regulatory bodies. It could be your medical laboratory councils or the associations, but they have a crucial responsibility that includes development of a policy to understand in each specific country which tests can be task shifted. I mean, from that list, as you saw in the previous slide, the question is which ones can be task shifted to lay testers, and also the framework for the training with certification and ongoing supervision. Other than the regulatory bodies, we have national program managers. I've already mentioned that they need to conduct a review and to assess the responsibilities and current roles for lay cadres, but also the other enablers, I think, is the adoption of the EDL that I've already mentioned from WHO, and ensuring that the results from point-of-care testing can be used for patient management. So from the publication we made, we also highlighted that task shifting should not compromise the quality of diagnostic testing and the professional standards. It should happen within the legal protection of those with appropriate levels of competency, together with protecting the patients. So we highlight that indicators of monitoring the acceptable quality of testing should be developed, and thereafter, in terms of sustainability, we are saying this shouldn't be an issue that we are creating a new cadre altogether, but it's existing cadres whose roles are reviewed. So this could ensure sustainability of the project. And the last point there, of course, more or less is highlighting the fact that the role of these late testers can evolve over time. I mean, if you have outbreaks, if you have new tests, as we see from the diagnostic pipeline. And the last slide that I have, basically, of course, is highlighting the fact that lay cadres are a critical component to our strengthened healthcare systems to support the decentralization of point-of-care tests to the last mile, as we have massive goals for universal health coverage, massive goals for sustainable development. And the key issue is to have improved engagements between our key stakeholders that I've already highlighted. And the last point, of course, is that for the real progress to be made, we need to adopt task shifting from WHO as it recommends. We need to also adopt the essential diagnostic list and adapt that to our own national EDL, but also into our own national policies of task shifting. And ultimately, we need to be adept, of course, meaning that we need to be very experienced in that. This is the end of my talk. Thank you. I'll hand over back.
Thank you very much, Z. A very comprehensive presentation and quite clear. You brought out the diagnostic availability being really low at points where our clients are at the highest volumes and in numbers. But also you brought in the aspect of considering the disease burden to guide which testing should be deployed at what level of our network, and challenges in implementing task shifting. We will move it now on to the next presenter, and our next presenter, as I indicated earlier, is Patrice. Patrice Chenju, please take on and run through your presentation.
Thank you so much. So thank you once more for inviting me to this session. It is my pleasure on behalf of our team, Global EGPAF team and countries team, to share with you guys today this work entitled Task Shifting for Point of Care Early Infant Diagnosis, Lesson Learned from Involving Non-Lab Worker into the process of analyzing EID. Just to provide some context is the fact that basically using point of care platform was an opportunity to decentralize laboratory service. And when we are talking about decentralizing, when we are talking about decentralizing laboratory services, is not just from a national reference lab to small lab or a big health facility to primary healthcare, but it's also within a same health facility from the lab to the entry point. We know that to make service friendly for patient, we need to reduce the time spent by patient at the facility when they are coming. The one-stop shop approach is the most efficient if the patient can benefit from the maximum of services. So the point of care technology that were used during this study were able to help analyze, to carry out HIV EID tests or viral load. But what we are going to share is our experience regarding only the EID, because the use of this automated technology and the assessment we did before launch give us opportunity through the patient flow to involve clinical staff into the analysis of sample. With your permission, I am going to rapidly share the global project elements, which has as a goal to increase the number of HIV-exposed infants whose HIV status was known and facilitate their initiation on treatment, and with an emphasis on ensuring that at-risk infants have timely access to diagnosis through incorporation of point-of-care testing into the national EID. So the project basically was a multi-country project implemented in 9 countries, and we had as objective to identify about 14,617 HIV infants. Through this project, we developed what we call an implementing approach. What does that mean? That consisted on optimizing the early infant diagnosis in each country, then strategically place the new point of care platform in order to increase access to EID testing and reduce the turnaround time. And because of that, we could have placed it in the lab or in the PMTCT service or in the maternal and neonatal child health service, depending of the results of the assessment. But also, as implementing approach, we had to select to ensure a good selection of product. We also have to ensure a good integration of and proper implementation of the point of care using the existing. Through existing, you need to understand existing staff, existing samples transport system, because from the very first beginning, we anticipated in terms of sustainability. So we didn't want to modify what exists at the facility. We want that through that support on an operational study, the Ministry of Health can leverage on that, and it will be easy to continue. We also had to strengthen the effective linkage to treatment, and of course, make sure that our tools and mechanism can help to generate evidence to inform effectiveness of the project, but also future scale up and information that the donor needs. And with what I just presented, you can see that we have a different type of health facility involved in the project, moving from the national health facility to the primary health care, which is here called integrated health centers. But we also have a number of questions that were explored into this project. And because of this session, we are going to focus more on the assessment of clinical, let's say, contribution of clinical staff, that means non-laboratory staff compared to laboratory staff. And to do that, we are going progressively to compare the internal quality control failure rates, but also the turnaround time from sample collection to issue results to caregiver. And then we are also going to share with you guys feedback from the in-depth interview that we had to those who participate to the project. Basically, during the implementation, all testers were trained and received a regular monitoring, including non-lab testers of those facilities. This was very, very, very important, the training. We emphasized on the training, and the training was done together. That means the non-lab staff and the lab staff were trained together with phases of theoretical training, but also practical training. And that was on-site training. That means that basically the point of care technology were placed where they were supposed to be run. We also have an integration approach package, which was progressive after assessment, with a package of activity per phases, which is helping progressively the environment and the existing staff within the facility to take over what you were expected in terms of the package of activity of EID. All testers had to pass the proficiency test, which was actually run by reference lab in the various countries, the 9 countries that were involved. And of course, we did an assessment which helped with site level team to better organize the management and the follow-up without disturbing the patient flow. For this comparison, we took data, we considered data for 3.5 months of routine EID and from 257 health facility. What was also important is that for this analysis, we consider end user related IQC failure rate, as well as the analysis included what we call the hub and spoke model, because not all the facility were having the platform, but we were linking surrounding facility to the main facility to increase the coverage and increase the access to the services. And in total, as I said, we had 257 facility. In terms of results, the first main results regarding the internal quality control failure rate overall and average was 6.1% over the period. And when we analyze the results, we observe that user-related contributed for 42%, the quality of the sample collection 27%, and also the manipulation of the cartridges for 12%. But what was also important as a main result was the fact that no significant difference in the overall end user related IQC failure rate was found between laboratory and non-laboratory personnel. In addition, both cadres routinely achieve an end user related IQC failure rate, which was below 2.7%, and you can see the p-value was around 0.7%. As I said, another key elements that were used to compare the impacts or the quality of analysis among clinical staff and laboratory staff was the turnaround time. We realized that with the point of care technology, the turnaround time from sample collection, the results return to caregiver, or from sample collection to ART initiation were less than 24 hours, and compared to 2 months that we had before when we were having only conventional EID. And there were no difference actually between the clinical staff and the laboratory staff. And when we consider what comes from the interview, we realized that basically the clinical staff, or which involved the nurses, the midwife, reported that the analysis with automate platform were very simple, less complicated, and those platforms seems to have improved ability to care without significant change in the patient flow. Overall, all involved were happy about the opportunity to use the platform and to increase the quality of the service toward the patient, and they clearly said that they would have recommended it as
Now I'll get to Z, and Z, our first question is coming from Pascal, and Pascal is asking, how do you envision a professional governance of lay testing cadres? And do you have some examples that you can share with the team that are attending our session today?
Thanks, Francis. I think the starting point is to have national policy. So this national policy, of course, could be coming from national program managers specifying explicitly on the role of lay testers, or it could, in addition, also come from the kind of human resource structures that explicitly say lay cadres are within this framework part of the resources. Or we can also have a policy coming from the laboratory councils that enable or clarify the task shiftable tests. Yeah, and lastly, also, if possible, like I've heard from Kenya, lay cadres have their own health association, so that also could help. But overall, I think professional governance could be an offshoot of the Medical Laboratory Scientists Council, because this also still falls under the jurisdiction possibly of the Lab Council, or the Lab Council can guide as to the governance of this. But lastly, I want to also emphasize the importance of giving the lay cadres confidence and job satisfaction. I mean, this is through the training that I've already mentioned, that which should be accredited, but also clear remuneration structures. They should be paid, and also there should be clarity on their career growth. Where do they go after being here? And in terms of answering the question in terms of country examples, I think Malawi is the best country that can give us their kind of like experience in this. They've implemented a lay cadre for point of care testing, but of course they were led by an NGO called Partners in Hope. And unfortunately, I think that system is still led by the NGO. But I think maybe in the next future, sessions, if we invite them to share with us their framework of scaling this up and ensuring professional governance, it could quite be helpful to create that kind of like community of practice to share beyond. Thanks.
Thank you very much, Z, for that very clear explanation. I have the second question. I'll get back to Pascal. She has another question, but let's get to Edward. And Edward is bringing in some very interesting aspect to this, and I will try to rephrase it. He's saying when he trained as a medical technologist over 40 years ago, there was general training on sample collection, for example, and maybe basic tests. These days, we have actually phlebotomists with professional organizations, and therefore we leave some of the basic things to the others, even when the mainstream practitioners can as well take it on. And his question is, can we take that approach to try and make sure that the different healthcare practitioners have some general basic testing and diagnostic understanding, so that they can then be deployed to do some of the basic tests and procedures that we cannot have all the technical people deployed to do all the time? Your comment, Z.
Thanks. Sorry, I was on mute. Thanks for that question from Edward. I think the key point here that we're trying to drive towards is that at primary healthcare level, we don't necessarily have laboratory trained people, your lab technician, your lab scientist. And the question is, that's where we want to have these lay cadres stationed. That's where we want them to have to be positioned. And in this day and age, honestly, I mean, especially with experiences from COVID, we have seen how patients have the ability to self-manage, self-monitor. And that's the kind of like the theme we're going with this, to say lay cadres are capable of also conducting these tests, given the fact that we're empowering patients, and lay cadres can be able to do this. So I concur with what he's saying, but our focus, I think, is just to give autonomy to these lay cadres at primary healthcare level, where there is no lab technician to be able to do these other tests. I hope it answers his question.
Thank you. Thank you for the counter comment. Now, the second question that was coming from Dr. Pascal is on safety protocols. So as we try to task shift, share responsibilities, we are seeing that there are critical tests dealing with microbes that might actually, we know that, of course, when dealing with samples, everything is potentially infectious. But if you have cholera in the mix and other pathogens, what are some of your comments on the safety protocols in terms of providing PPEs and vaccination and general monitoring of the health of the lay providers, to make sure that as they take on additional responsibilities, they do it in a safe way?
Thanks. I think this more or less will follow after accredited training. So once we design frameworks for trainings which are accredited and which touch on different pedagogies of different priority diseases, because I mean, disease prevalences vary on where you're based, but ideally if they touch on the specific ones for the different areas, we can then more or less be clear on safety protocols. And I think this will link back to the governance again, whether it's linked to the medical laboratory councils or lay cadres will have their own council in place to more or less ensure that people are trained, they understand issues around safety, but also they are supported to have all the necessary equipment, PPE, if need be, especially when we have new outbreak of diseases that are extremely infectious, like we had with COVID at the beginning, when we didn't know whether we have to do it in a biosafety cabinet or not. So as long as there's governance and there's a body that supports this also, I think it could go a long way to protect these cadres and give them all the best support they can. Thanks.
Thank you very much, Z. Welcome back, Patrice. I know that you ran into trouble, but we'll get to you at some point. We will be running a survey just to extend this discussion, given the time that we've lost, but also given that this is a very interesting topic and we cannot exhaust it in the time allocated. So that survey should be getting to you, and please kindly respond for some of those questions and provide the comments that then we will get back to our platforms and make sure that the discussion continues. Now, please confirm that you can hear me.
Yes, we can hear you, Francis.
I can hear you, Francis.
The survey is already on right
Okay.
now. People can just answer and then move to the next question.
Okay. So as we continue, we request that we use about 5 more minutes of your time. Again, our apologies for the lost time today, given the technical difficulties. But please respond to the survey. It is running currently. But a quick question to Patrice. And this is again coming from Pascal. And Pascal is asking, how did the EQA performance compare between clinical and between clinical and lab staff? Because your task shifting was moving the diagnostic procedures from lab people to other medical practitioners who are non-lab. And so the question is, how was your EQA performance comparing between lab and non-lab practitioners?
Yeah, thank you so much for the question. I hope you are getting me.
Yes.
Basically, they were receiving a blind package of sample from the reference lab. And, you know, whether you are non-lab staff or lab staff, when it comes, they were having like IDs, and basically they were running the test, and those results were assessed by the reference lab. And it is only after the results that now there were identification of who did what. And this gave opportunity. That is one for the one for the proficiency test. But also what we want to mention is that basically, as the different analysis were run, we were extracting from the results and compare between clinical staff, which are nurse, midwife, and lab staff, so that we had opportunity, actually one, as I mentioned, to compare the EQ, the internal quality control rate, but also during the proficiency test, we have opportunity to compare the results.
Thank you very much, Patrice. We have one general comment. We will also be sharing on the screen shortly one of our documentation where Z did the lab culture documentation, where Z actually did a small write-up, and will encourage you again to read. We will also be sharing again that lab culture document with you on the different platforms that we have. And it relates again to task shifting. Now, one general comment as we prepare to wind up is on task shifting responsibilities. And Pascal is saying that task shifting actually has benefits, but it comes with responsibilities. Safety, for example, which we've spoken to, for those that are taking additional roles that they may not necessarily be comprehensively trained for. Compensation related to the time that they use to do the task that is added to them, and a few others. And so, as we plan to do the task shifting, it is important that we try and cost all these additional things that come with it, so that we are not in the end caught in a position where we cannot support the task shifting initiative, which should be cheaper than deploying laboratory people to very low level facilities where tasks can be done by non-professional lab workers or low trained professional lab workers. Colleagues, we are coming to the end, and on the screen is the lab culture documentation. I'm also glad that my colleague, Dr. Marguerite, shared the link to the article published by Z. We will also be sharing with all of us the slides for today's session and the recording amidst the limitations and the difficulties that we've run into. Apologies again. And so as we come to the end, I will ask Z, can you give us your closing remarks?
Oh, thank you. Thank you, Francis. I hope you can hear me loud and clear. I think for me, the key issue here is that point of care lay testing is an area of high priority for investment, mostly in our primary healthcare facilities, and it's going to enable us to have equitable access to the multitude of essential point of care tools that are coming regularly. I think as we have even more kind of treatments coming out and even tools coming out, it becomes less acceptable to have long turnaround times or even delays associated with centralized testing services. So I think in most of our projects, in our countries, in our programs, let's consider what kind of framework we need to follow. There's a lot of evidence that's already available about the effectiveness and also about how to implement these things. So let's sit down, draft on how to consider integration and implementation of lay cadres for point of care tests, especially in primary healthcare levels. Thank you very much.
Thank you, V. Thank you very much. Patrice, I'm getting to you. And as you give your closing remarks, you could as well deal with one quick question that has come from David Ocheng. And David is asking, why is task shifting targeting laboratory science only? Over to you, Patrice.
Yeah, thank you, Francis, and thank you for the question. Hoping I got very well the question, which is why lab test task shifting is targeting only laboratory science, correct?
Correct.
Yes, thank you. So basically, when we assess the situation of the, let's say, the PMTCT, we realize that in many of our country in Africa, PMCT, I think pediatric care and everything around PMCT is where we need to put a lot of effort. And basically, the idea behind here were to see how we can help to increase the access to services, and this during the situational analysis, this aspect, task shifting from lab to to clinical staff was one of the aspects on which we can act, and we can act quickly and see the results. So that is what I can share. There are several aspects of it, but we saw that this aspect was one aspect on which we can act and quickly achieve the results. And in terms of my closing remark, what I'm going to say is that task shifting is actually a great opportunity. And it is very important because from our experience, we saw an increase of coverage of access to EID service and the number of children identified. And we actually have life safe, which is the ultimate goal of the healthcare. And when you have an opportunity which actually goes in the direction that is expected, which is saving the life, I think it is very important. As Z say, we need now to work around that, because as we are bringing a new intervention or a new orientation, there are also some other related aspects that are coming in the course of the implementation, and we need to monitor that so that we don't have the reverse effect. So that is what I can say. Thank you. Over.
Thank you very much, Patrice. And just to add and agree with the comments from other colleagues on the chat, task shifting has actually happened across the different technical areas in healthcare service delivery. In Uganda, we initially started with prescription of ART as a function for medical officers only. But as we speak now, even lay cadres are prescribing. And so it moved from medical officers to clinical officers, then nurses, and finally we have lay cadres actually prescribing ART for patients who need them. And so this has been something that has happened across the board. Colleagues, thank you again for being with us. Our apologies for the disturbances we've had. We hope that this is the last time, and we'll try to mitigate for all that we've learned from today's session. Until our next session, good day from us, and enjoy the rest of your day, evening, and afternoon, wherever you're joining us from. Thank you, and over.